move on to the next talk here, and it's going to be on AMD, neovascular AMD, and Dr. Vinay Garodia. He's going to give a talk on is extension and maintenance of 4 months treatment interval possible in neovascular AMD. Dr. Giridhar, please come over here. You'll have to ask questions from here. So you come. You have to come.
Thank you, sir, and good afternoon, friends. So after a very interesting discussion on DME, I think now we are going on to the next where anti-VEGFs are used maximum. In fact, that's where the anti-VEGFs came in for, and now we have expanded the usage to DMEs also. So we'll be talking about how we can treat AMDs better, and how we can do the treat and extend protocol, and how best we can follow that. So very important parts in any treatment is prompt diagnosis and initiation of treatment. And second point is most important, that you have to educate your patients what you're going in for. So something like what Dr. Raja was saying, that first time the conversion was about 42% for them. But if you have convinced them well about the need of multiple injections, the second time conversion is going to be 82%. That is not a surprise. So if you counsel them well, your compliance for the future injections is going to be better. So it's very, very important to educate and discuss with the patient right at the beginning that they'll be needing more injections than one injection. And initial treatment has to be done till the lesion becomes inactive. And after that, we have to try to decide what strategy to follow. So there can be options of either we go for a PRN, we go for a fixed dosing, or the topic of discussion today, the treat and extend. So what we have found from the studies is that after the initial inactivation, there's about 40% patients have a recurrence that happens within 1 year, and about 80% of them would recur within 5 years. So we have to decide about the long-term strategies. But one thing to note out here is that there are still 20% of the patients who would still not have a recurrence happening. So probably that is a subset that we are going to be over-treating by doing our treat and extend protocol. So we have to have some ways, hopefully in the future, to try to find out which are the patients not likely to recur in the future, and they can be separated and spared the treatment. So that's one thing we can, that's something for the future we have to look at, right? So the basic therapy for continuing, there are two options. One is after either we do a fixed Q8 dosing as advised by ILIA people, or we go for a proactive treat and extend dosing. So the goal should be to maximize the visual outcomes with the minimum burden. So we cannot keep doing every 2 months to a patient who possibly doesn't require it. So we have to maintain the good vision without causing any, minimizing the burden. One thing is important for treat and extend is whenever the patient loses vision or whenever the edema comes back, he loses some vision whenever you treat them again. So PRN therefore is not a very, very attractive strategy. And as someone said, the chances of dropouts on PRN are much more. So we should try to minimize the recurrences in the best possible way. So the basic principles are that we have to titrate the treatment intervals for each patient, because every patient, every eye, and the stage of the disease demands different timings. So at some stage, it may be requiring every 2 months injection, but some stage might be okay with 4 monthly. So your titration has to happen, and it has to be more dynamic. You should be ready to change. And every time the patient comes to you, he gets an injection, and the test done on that day determine when he's going to be called next. So that has to be explained to the patient. So patient comes for the injection, he is investigated that day, the visual acuity, OCT, and everything is done, and that determines whether he's going to be called at what interval the next visit. So let's talk about Altair, which compared the two options of adjusting the treatment intervals by 2 weekly interval vis-a-vis 4 weekly intervals. So they were randomized into the two groups. And so this is basically the graphical representation. So after fourth injection, they were randomized into every 2 weeks adjustments of increasing, decreasing, or maintaining the duration vis-a-vis 4 weeks intervals. So the criteria were very simple. So if the patient was stable without any fluid, then we extended the interval by 2 or 4 weeks, depending on which arm you were there. If the patient was responding, but still the fluid was there, then we maintained the same dosage. And if the patient was worsening, when the fluid was increasing, or new fluid, or decrease in vision, or hemorrhages coming in, then we decreased the interval. So with this, we found that both these strategies work pretty fine to maintain the visual acuity in the long term. And it was also found that about 60% of the patients could be maintained at Q12 intervals at the end of 2 years, and about 40% of them could be maintained at Q16 as well. So that was quite exciting, and both the groups could maintain the vision well. But what was also found that if you're doing a 4 weekly adjustment, the chances of patients going back was more. So they were about 77% of patients could be maintained at the same. Whereas if you're doing at a 2 weekly, more conservative kind of an adjustment, about 96% of the patients could be maintained there. So I personally follow a 2 weekly adjustment rather than 4 weekly, because that's like there's a lot of fluctuation that is happening in the whole thing. So I don't like that. Now, coming to brolucizumab, they also came out with a Hawk and Harry study, and they found that about 50% plus patients at the end of 1 year could get a Q12 interval. That was quite nice. But the problem happens when you extend it further to 2 years, then you realize a lot of them were dropping to less than Q12. So there was only about 40% of patients could be maintained at Q12 interval at the end of 2 years. Now, that is possibly because, as we'll be explaining later, that the half-life of brolucizumab is lower, lesser than that of Eylea, and the molar dose is more. So maybe initial first year, because they are giving the loading doses a very high molar dosage, therefore initial year they can maintain at Q12 better. But as that initial concentrated medication effect goes down, as they go to the second year, their Q12 is also not being achieved in more than 40% of 60% of cases. So that's something of a concern. So the same thing you can see compared to Eylea, you can see that the patients who achieved a Q12 or Q16 were maintained at that. Rather, the percentage of people maintained at that rather improved over a period of time, as we would expect it to be, because as the disease is becoming less active, we expect more and more people to be maintained at a lesser frequency dosages. Whereas in case of brolucizumab, it was the other way around. So that is something of a concern. And we have got some initial data from faricimab, which suggests that these patients do even better with a 3 monthly or a 4 monthly interval. But the data is very new. The criteria that were taken was very different. There was very rigid kind of a thing. They were not flexible about changing the criteria. So these are early days ahead right now. So coming to the real world evidence, the real world evidence has shown that treat and extend works quite well. And there are multiple studies which have shown. So in this particular, you can see that over the fourth year, the number of injections had gone down to about 2 to 3. So there are multiple studies which have shown that these injections work. And as the year goes by, the number of injections per year go down. So to summarize, then we have got this Altair and ARIS that we have. But we also have data saying that, for example, in the study, we see that as in Movefield study, you can see the first year they got 7.4 injections, second year was 4.9, 4.2, even goes down to about 3 injections. So more and more patients, and about 50 to 60% of patients are maintained at Q12 or better. So that's interesting. Now coming to the last part about why we have got so many options, and I think though this is a Bayer-sponsored symposium, so of course everyone feels that Bayer aflibercept is better. But if you really do analyze it, you do find that as of today, what we have, this seems to be the better molecule. Now, what is important is the binding affinity, the elimination half-life, potency, clinical targets, and the molar dose. Now, these are important when you talk about the efficacy and the durability of the action. So coming to binding affinity, we know that the aflibercept has got a very, very high binding affinity to VEGF compared to the competitors ranibizumab and brolucizumab even. So it's about 10 times more affinity than brolucizumab, and more than 100 times more than ranibizumab. Faricimab, we don't have so much of data, but it seems to be similar to ranibizumab, so it's also going to be low for this. The second is the half-life. So when you look at the half-life, again, aflibercept does better compared to ranibizumab, and brolucizumab, surprisingly, which was supposed to be Q12 interval, has got the least of the half-life. That is because of the smaller molecular weight of that molecule compared to the others. So again, coming to the potency also, potency is the concentration of the drug required to have the effect in the number of moles point. There again, we see aflibercept scores over the other options available with us. And the other option now is that what if we combine other pathways also along with VEGF? So like brolucizumab and ranibizumab work only against VEGF, whereas aflibercept has an additional platelet-derived growth factor also, which possibly gives them some benefit in the DME cases. And the newer one that is coming in, faricimab, has got angiotensin 2 arm as well. So we still don't know how effective is that going to be, but that's what we have to watch at, that along with anti-VEGF with angiotensin 2, whether it will be more effective or not. But again, that was, as was shown earlier, that if there's a low VEGF levels, then probably angiotensin 2 doesn't play that much of a role there. So, but those are all theories. We have to actually get our own real-world data before we decide if faricimab is going to be any better than aflibercept that we have. And the last part is the molar dosage. Now, if you see the equivalent molar dose of aflibercept, if you compare that with the other, so we give 2 milligram of aflibercept vis-a-vis 6 milligram of brolucizumab. So we are, as it is, giving 3 times the dose when it comes to weight. And then on top of it, when the molecular weight of that compound is lower, so number of moles that you are putting in is about 10 times, more than 10 times. So you're basically putting many molecules inside the eye, and that is possibly the reason why we are having better effect in those cases which are not responding to aflibercept. They respond to brolucizumab. But does it come with a price at a cost? There is a more side effects that we know that happens with it. So maybe that is the reason for it. But I would rather be happy with aflibercept, which gets the same effect at 1/10 of the number of molecules inside the eye compared to something which we are using more than 10 times the molecules inside the eye. So this again, you see that these are the graphs that you can see that the effectivity level. So the half-life inside the eye, the effectivity, the data has been projected to be 36 days for ranibizumab, 52 for brolucizumab, and 71 days for aflibercept. So there's a benefit of about 19 days over and above brolucizumab that is there. So to sum it, how do I personally do the treat and extend? And I would like the opinion of the house to see if there can be any changes. So for me, aflibercept is the first choice for AMD. I reserve brolucizumab for refractory cases only. I don't use it as the first choice. But one caveat I would like to tell, that if you use brolucizumab, do not call the patient after 3 months, the way we do for Eylea or other cases, because these patients may, though a very small person, may have an inflammation happening. And if you don't catch it at the right time, the courts are not going to listen to you that you didn't call the patient on the right time. So you have to still maintain a very close follow-up if you're using brolucizumab. So that is very important. So it may not be a real treat and extend. You have to keep checking them every few weeks to see that how they're doing. I do discuss the treatment plans with the patient attendants. I don't go with 3 loading dosages. I go with inject monthly till I get the response, and then I plan to extend from there. And once stable, then I would adjust Q 2 weeks rather than 4 weeks. And if I have a patient who's at a Q16, I somehow feel more comfortable calling him at 2 months for a checkup rather than calling him straight after 4 months. Of course, if the patient is from outstation, I would call him after 4 months. But a local patient, I would prefer to see him after 2 months. And of course, SOS is always there with him. And as I said earlier, there's always a 20% of the patients who probably won't require any injections at all. So when we talk about 40% patients are switched to Q16, actually 20% of those are benefiting from you, and 20% were anyway not going to be needing even that Q16. So we have to think about whether we can extend that from Q16 to Q20 or Q24 also. That's something for the future that we have to work on. Thank you.
Before we, nice presentation, sir. Before we start the discussion, what do you mean by once? Can you show the last slide, please? That is, once it is you have finished the loading dose. What is that? One stable adjust Q 2 weeks and not Q 4 weeks. What do you mean by that?
So that's the Altair study. That in Altair they basically increased or decreased the duration by 4 weeks vis-a-vis 2 weeks. So I prefer 2 weekly adjustments.
That is when you start the TNE, right?
Yeah, for TNE.
That
yes.
is every 2.
Yeah. So like if the patient is coming at 8 weeks and he's stable, I'll make it 10 rather than 12.
Okay. So we'll start the discussion again, like the DME. So I just written down a few questions. We'll start with the panelists. Number one is, what is your first choice of drug for in wet AMD? Does it depend on the morphology? If the patient can afford anything, let us forget the affordability. The patient can afford anything. Mahesh, what is your first choice? Is it aflibercept or is it?
Now it's aflibercept actually.
Pardon?
It's aflibercept.
Aflibercept.
Yeah. Whatever type of wet AMD, it's aflibercept.
It's aflibercept. Okay, thank you. Hemant, any difference of opinion or same?
Same.
Okay, anyone having a different opinion? No. Okay, great. So Bayer is very happy. So second question. Loading dose. Now, Mahesh, do you give a loading dose of 3 injections initially, or you have a different protocol if you're giving aflibercept?
Sometimes there's a slight difference in the protocol. After the second injection, if it is completely dry, I may start the loading dose then itself. Instead of giving the 3rd injection at the next month, I'll probably call him 6 weeks later.
6 weeks later. Okay. Hemant, any difference of opinion?
I think you meant you start treat and extend. Yeah. So I would follow a very similar, but not less than 2, and 2 would be the minimum. And then
You're talking about T&D.
Yeah, then I start treat and extend.
okay.
No, when you say the loading dose, the
So
loading
coming
dose
to
would be-
treat and extend, that means in all patients with wet AMD, after the initial loading dose, you immediately start TND.
Yes.
He's saying loading dose maybe 2 also.
Two also.
That is
Two
what we
injection
do.
also.
Yeah, that's what. Loading dose is 2. Maybe 2.
Maybe,
If it is
maybe.
dry. If it is
Yes.
dry, you stop with 2 and then you
with
follow up.
complete visual improvement.
Okay.
That's what we
Okay.
do.
Okay.
But sir,
You see,
sir,
that is not so common. You see,
Correct,
Brandon
correct.
is not
so
so
it's
common.
not so.
It happens,
We
but,
analyzed our data.
Yeah.
And majority, we looked at what was the minimum number of injections AMD patients had. They were about 2.2 or 2.5 is what is the average. So I know majority did receive 3, not less than that. But everyone received 2 at least.
Yeah.
So that's
I
like,
mean, yeah.
sir,
That's-
if the
that's
patient if the patient is still not dry and
No,
you feel
that's-
there's a potential for improvement after 3, when would you give the 4th injection? After 4 weeks or after 8 weeks?
No,
Continue at 4 weeks.
Doc, we'll come to that.
Sorry, sir.
We'll come to that.
Sorry, sir.
See,
Sorry.
what they are saying is they are looking at dry. I mean, that is once the macula is dry, IRF is not there and SMD is not there. After the in ILIA you have the scheme, so 1+1. So the second injection is free. So he says he'll give the 2, and at that moment of time, if it is completely dry, he will not give the third in probably immediately. He will, he may delay it a little.
That
bit. That's what he said.
TNE
Yeah.
started. TNE started
Yeah.
earlier.
Okay,
Earlier.
that's coming later. My question was, if it is still not dry,
Yeah, no,
would
no,
you
it's
go
not-
for Q8 after that, or would
No,
you
no,
still continue with
it's
Q4?
not
That question has no validity
That-
now
no, no,
because the
Yeah.
condition has become dry.
Yeah.
Ah.
So any difference of opinion? I mean, it's all the same, right? Okay. Now, next question. Hey, Mahesh, do you treat all your patients with wet AMD on a TND basis, or do you have any other? I mean, that is, once the macula is dry, say you give 2 or 3 injections, it's totally dry. Now you straight away go into a TND, or you practice PRN?
It can be a treat and observe. It's not a PRN. So if it's absolutely dry, then I'll probably prolong it by another month or 2 weeks and see how that particular patient behaves. So if it's going to recur it in that 1 month, then I alter it a little bit. So it's not that if it's absolutely dry, I inject and follow. So at that point in time, there's a little modification of treat and observe can also be.
So what you meant is that you will look into the behavior of the disease during the next 2 or 3 months to see how frequently they need the injections, and based on that, you take a call, right? Hemant, do you agree with Hemant? I mean, Mahesh.
I would also do very similarly on that.
Great.
The only thing is like this, that I also discuss this with the patient. A lot of them feel that they would like to do the PRN, which I then leave it to the patient's option.
Okay.
If
fine.
they're agreeable and they understand the concept of treat and extend only,
Okay. And in all this, I mean, do you have a difference if it is a type 1 or a type 2 or a type 3? Because a type 1 is always quite safe, whereas a type 2 and a type 3 are more aggressive. So do you have a different protocol when it comes to the type of wet AMD that we are dealing with? I mean, I felt that that's quite an important issue. So is there any difference of opinion as far
type
as...
2 generally they do require more number of injections. And we
So you
follow
would
them
like
up.
to
So
follow up
they
the
tend to
type
be
2
a
and the
PRN
type
sort
3 more frequently
than
probably a type 1, right? Type 1, you may probably, once it is dry, you may call them after 2 months or something like that, because you know they may just come back with a mild SMD. Whereas a type 2 or type 3, you may like to follow up more sincerely and inject. Okay. Anything else, George and Ashish?
Yeah, to the question which you asked after the loading dose, I generally stick with 3 injections unless it has maximized the vision with 2 injections, like what Dr. Mahesh was saying. But then if the patient is outstation patient, stick with treat and extend, because if you are thinking of you need monthly follow-ups to see what's happening.
Yeah.
So if it's an outstation patient, strictly on treat and extend, and treat, extend, and stop. That's what I practice.
Outstation and very elderly patients.
Elderly people with multiple comorbidities, stick to the treat and extend and stop the regime. There is a regime called treat, extend, and stop. So just treat and extend all the injections at once it reaches once in 3 months injections. Then stop the injections and see, because the drug doesn't last more than 3 months usually in the eye. Stop and see. But then if you're stopping and seeing, after stopping, follow the patient 1 monthly
Patient will come back with a
After, I
hemorrhage.
mean, if it is dry macula after the last injection,
George, a lot of
yeah.
these patients will come with a hemorrhage actually.
Yeah, not
No.
that you are not losing the follow-up.
Patient will not come.
Yeah.
Unless you scare the patient, he will not come.
So ideally, if you're doing a treat and extend for 2 years, he should be on once in 3 months injection. Invariably, if the patient is having edema or not. But then that is not practical. So like after you reach couple of injections once in 3 months, stop and see monthly follow-up and see whether activity is there. Then you can extend only on follow-up once in 3 months. That's what we follow.
Giri, I don't like to discuss too much with the patient, because experience has taught that in case, say, we observe after 3 months, a lot of these patients, I do not have numbers, will come with some macular hemorrhage after some time. And then the scenario may not recover completely. So in AMD specifically, after it has maximized, then all of them patients, irrespective, I will at least scare them that you have to have this injection after some interval or so, which we have found out it is best is around, say, 10 weeks or 12 weeks. But they have to have that.
Once in 3 months. For how long?
We continue. Actually,
You see, I personally would not say, okay, disease is over and you stop it now.
No, I think Lalit, see, once we
Unless,
give this TNE once in 2 months or 3 months,
Yeah.
and in about 3-4 visits when
Yeah,
we do the
if 3-4
OCT, the
visits-
macula is totally dry.
That means 1 year. That means 1 year, approximately a year.
No, what I'm saying is, if the macula is totally dry, I think, I mean, at least I would like to just see for extend it a little more and
Little
see
more.
whether
Yes.
we can, delay the injections even further.
But I agree, the word stop, it does not come.
Yeah,
So I
stop
will-
doesn't
yeah.
come.
But the patient should be on follow-up.
Follow, yeah.
After the first year.
No question of stopping, but the follow-up in the interest of the patient, not to come less number of times to the hospital, we can extend it. Now,
I would
yeah.
like to look at extension up to 4 months also. You can extend them rather than stopping it.
Stop.
I would probably look at.
I think as far as the AMD is concerned, we can't say stop because I think it continues. We have hardly very few patients. He also mentioned 20%. Probably the number is very small. Otherwise, they'll keep on requiring some
Yeah,
treatment. DME is different. That's how probably the requirement for the injections in neovascular AMD is so much, which is not there for diabetics. The problem is diabetics will be stabilized after some time and they'll be okay. So that happens that we have seen that. At least I have some of my patients, those who we started treating in 2007, they have received in neovascular AMD more than 100 injections. I have
You see,
such
that is
patients.
true because
Yes.
diabetes has other parameters also which get controlled and the disease may get altered.
So I will just summarize what has been said. One is loading dose, yes, 2 or 3 injections, or until the macula gets dry. First few months, 6 months or something like that, you follow the patients very carefully to study the, behavior. And if the need for injections is quite frequent, then immediately shift them to TNE. Isn't it? That's a thing. And of course, depending on individual situations like a long distance, AFO and all that stuff, you can always modify this thing. Now this Q16, now, what percentage of your patients really reach that level where they need an injection only once in 4 months, 5 months? Is it 20%, 30%? Or
That happens only after the first 2 years.
2 years, yeah.
That is after the first 2 years.
Exactly.
So that stage is what I'm talking about.
Yeah.
There is a data called 8-year study on treat,
Yeah,
extend
yeah.
and stop.
Yeah.
8-year study.
Yeah.
And that is the highest. 35% had 15 letter gain, where they have continued treat and extend for 2
Yeah.
years.
Okay.
And after that, they have tried what I said, stop and frequent follow-up every 3 months, and they had the data. So when to, there is no end point for 8 years
Yeah.
treatment is difficult.
Okay. And last question, not directly related to this session, but any of you use brolucizumab as the first line of treatment in wet AMD? Any of you? Just to understand the practice pattern, that's all. None of you. None of you use brolucizumab as the first line. Ramesh is using. Okay.
Yes, sir. We used it primarily in PCV cases and in type 1 AMD cases. Yes, we have used it.
So do you give loading dose of brolucizumab?
Yes, sir. I give those.
Three monthly?
Monthly,
Monthly.
three injections. 3 month, monthly, 3 consecutive months. Yeah.
Great. I mean, no artist will be happy. I mean, of course, it's all individual. I mean, choice. I think everywhere there's a generational shift. The way we think and the way the younger generation thinks is far different. Yeah,
But
that's the
Ramesh,
thing. I mean,
Ramesh, it is only type 1,
yeah.
not type 2 membrane.
So, if you ask me, I will never repeat a brolucizumab injection at the second time, not before 8 weeks. Minimum, I wait for 8 weeks,
So loading
and
dose,
after that
yeah.
only I inject. Huh?
Same
Yeah.
thing, same thing. I always give brolucizumab as PRN and
Yeah.
never before it.
Yeah, so I never give,
Because-
even if I have to
because
give
most
the
of the
loading
side
dose.
effects, a
Huh?
lot of the side effects, IUI or whatever occurred
Yeah.
is what you were also saying,
Yeah.
increased concentration, increased molecules inside, is because of this frequent injections. You see, why is the difference in India is because majority of us do not give loading dose in brolucizumab. And in majority
Yeah.
of the patients, it's a second line of management and then the first.
That's what.
But having said that, predominantly in patients who have this membrane under the RP or PCV kind of structure, it is better rather than in type 2 or type 3.